Any copying, distribution, or public performance of this video or slides is strictly prohibited and may subject the offender to civil liability and severe criminal penalties.
Okay, our next speaker is probably tired because there's a lot of presentations at this meeting. Dr. Todd Scheyer graduated from Texas, San Antonio. He's a diplomat of the American Board of Periodontology. He currently serves on the Board of Trustees of the AAP. He practices based at a clinical research center in Houston, Texas with Dr. McGuire. And he's published numerous articles and has contributed to 3 textbooks. I'd like you to help me welcome Dr. Todd Scheyer. Thank you.
Afternoon, everybody. I first want to thank the Academy for giving me the opportunity to present. The way this was brought to us to present on the topic of soft tissue augmentation to optimize the prosthetic outcome was for me to defend or not really debate, but give the option of saving teeth and treating the defect with soft tissue. I think you'll see from my presentation, certainly in the beginning, that us as periodontists want to be equipped to deal with all situations. And oftentimes the situation to save teeth and augment the defect with soft tissue is driven by a patient or a restorative doctor. So by no means do I want to discount the beautiful work of our previous presenter. I will just obviously be working more towards saving teeth, which is something that periodontists can do very, very well with an incredible amount of evidence in our literature. And it's about the smile. It's about our ability to provide the patient an aesthetic result, whether a tooth or an implant. There are a lot of issues that come into designing the smile, from the micro-aesthetic elements to the macro-aesthetic elements beyond the lips. And I think we need to take all these things into consideration as we're deciding whether to place an implant or a fixed partial denture. This is a case my partner shows frequently in regards to the power we have in our hands to augment a case with traditional periodontal mucogingival surgery and save teeth and provide a patient a long-lasting, in this case, a 10-year follow-up of fixed partial denture with augmented soft tissues. In my hands, whether it be a fixed partial denture or an implant-supported restoration, the provisional restoration is the key to our success. The idea of guided soft tissue regeneration to provide the optimal, mature soft tissues before a final restoration is developed is something that I hold very dear to my practice in regards to implant dentistry and traditional periodontal therapy. That this provisional restoration must support the developed tissue through augmentation procedures or tissues that we're trying to maintain in a preservation approach with a provisional restoration. So part of this synopsis for this program was how do we deal with post-extraction buccal plate resorption? And it all comes down to, understanding this defect and how it got there, the reason for the tooth failure, what are the volumetric needs of reconstructing the defect, be it hard, soft tissue, or both? What are our treatment options? What are the patient factors and expectations that come to the table? And how will we provisionalize and finalize this case? We must avoid ridge defects when we can. So thinking ahead of tooth extraction by preserving alveolar ridge defects is critical. We need to look towards the evidence, although it can be debated all day long. We need to look to the evidence that we do have about treating defects and saving teeth. Risk assessment is key, and we'll go into that in just a moment. And avoiding complications, obviously from the standpoint of our own complications, and then how do we deal with complications that present to our office that we're asked to repair, all in order to optimize the outcome. These are things that many of my mentors incorporated into their practice every day. We still use techniques such as these in regards to root resection. Today, with the success of implants, they're used less and less, but I don't think we want to completely abort these options in treatment because there is some very nice literature out there that shows of long-term success with these treatment modalities. But we must consider both options thoroughly, taking into consideration what's the best long-term prognosis, the cost effectiveness, and of course, is it in or out of the aesthetic zone? Most of the studies that we'll talk about in a moment are dealing with implant functional success rates, not aesthetic rates. And how this success leads toward the best aesthetic outcome. What's going to provide the patient, the restorative doctor, and us the optimal aesthetic outcome in the premaxillary area. So implants or teeth in the aesthetic zone. Which one do we select and why? And if we select a certain modality, how are we going to get through the process? Let's touch a bit on the evidence now. For clinical complication rates, a nice assessment by Dr. Goodacre is looking at a potential complication rate of fixed partial dentures of up to 27%. 18% for caries, 11% for needing root canal therapy, and a 7% loss of retention. For implants, some of the research shows success rates up to 97%, depending on the location of the arch and the bone density. Unfortunately, though, much of the available evidence for single-tooth implants is not in the aesthetic zone, or if it is, it doesn't have long enough follow-up to really give us good guidelines for success rates or aesthetic success rates. So these optimal conditions may not be applicable to most of our practices, given that this type of data or this type of research is conducted in a very a perfect situation, so to say, not the everyday grind of our private practice. The European Workshop on Periodontology found that most importantly that there was a lack of standardized outcome, making it very difficult to compare papers that exist on aesthetic outcomes in implant dentistry. In 2 recent reviews, the same thing was found, that comparative studies just don't exist, allowing us to really make strong answers or create strong answers on comparing single-tooth implant restorations to the fixed partial denture. We do know from classic literature that teeth with a poor or questionable prognosis can be treated and maintained for many, many years. And this is what I'll be using to help me convince you that we don't want to dismiss our classic periodontal therapy and rebuilding the edentulous site with soft tissues to optimize our aesthetic outcome. With success, we understand the definition of a favorable or desired outcome. This could be considered in implant dentistry a functional success, but certainly not an aesthetic success. And if we're left to repair, potentially replace a defect like this, we have a very difficult situation to encounter. Not only do we have the loss of hard and soft tissues, but relatively no running room to build an emergence profile. That's probing 1.5 millimeters from the gingival margin to the platform. In cases such as these, where the implant is certainly integrated, but how will we correct this when the implant is placed outside the alveolar housing and has left us with a defect that is very hard to recover from? A case like this, where porcelain work has been done very well, it would be hard for most of us to argue which is the implant on 8 and 9. But when we reflect soft tissues, we are left with a different situation. Again, very hard to recover from a defect such as this. Success with periodontal regeneration is very cut and dry. You either have it or you don't, based on the definition. The same with osseointegration. We either have it or we don't. But with aesthetics, this is more a perception of beauty, and it takes the patient's account into consideration on what they believe is aesthetic. We all have failures and complications, and this is what we're trying to avoid. It's a difficult factor or issue appearing unexpectedly and changing the existing plans, methods, and attitudes. So how do we avoid these in our practice via implant dentistry or traditional fixed partial dentures? This is a schematic that my partner has taught me over the years, and it's critical. It's become a critical part of me communicating with restorative doctors, our patients, and I think that it's really key to understanding all the issues, regardless of the treatment modality we're talking about. The communication, we need to be able to do this effectively with our patients and our referring offices. We need to use things such as this that we've developed many years ago and have shared with the Academy in regards to making sure that the restorative dentist has really sat down and thought about the elements that go into smile design by looking at cases together with them and making sure that the patient's perception of aesthetics is taken into consideration. Utilizing provisional restorations to transfer the expected outcome is also a key to success. Whether it's for crown lengthening, ridge preservation, augmentation, or dental implants, provisional restorations are key to communicating properly and understanding expected outcomes. So if we have good communication, it should help us with the patient understanding realistic expectations, not just expectations for the patient, but for the periodontist as well. This is a great study by Vince Kokich Jr. that talks about the threshold of noticeability. And what I want to point out on here is that the lay person, the general dentist, and even the orthodontist, it took up to 3 millimeters of open gingival embrasures to have a threshold of noticeability. With the gingival lip distance or a gummy smile, up to 4 millimeters. All of us in this audience, I'm sure, would be much more critical of that. But we need to take these things into consideration when we're speaking to our patients. When we're talking about referral dentists, as I showed before, these referral slips to help the dentist talk to us, we really need to have an honest and open discussion with that referral if root coverage is desired, to what point? What is their expectation in root coverage? We should all know our Miller's classifications and what we can expect from mucogingival procedures, but does the restorative dentist and the patient understand? And furthermore here, is there hard or soft tissue loss on the adjacent teeth? If so, this may limit the amount of root coverage that is possible. So we're providing them some understanding of our limitations from a surgical perspective. Periodontists kind of want to always shoot for the bullseye. We want 100% root coverage every time. But I think we also need to be realistic on this account that we have the ability to achieve that. We have evidence to tell us that we have the ability to achieve 100%. But can we predict this all the time? Not necessarily. And we certainly don't want to transition that to our patient, that we're going to hit the bullseye every time. Procedural issues hopefully are a given, that we all are equipped with the gift of good mucogingival procedures or dental implant procedures, but it's a lot more than just our surgical skills. It's the patient factors that are brought to the table, whether they're a smoker or have systemic issues. The defect classification, which we'll go into more detail in a moment. The surgical technique we use, of course it needs to be good. The postoperative care, which really plays into the idea of restorative and lab support. Restorative and lab support comes in with the provisional restoration. Is the provisional restoration contoured properly? Is it polished properly? Is it modified at the appropriate time? Is it perhaps delivered at the appropriate time? These are all the procedural issues that become key to ridge reconstruction. And hopefully all things will meet in the middle and provide us the best outcome. Sometimes they'll be separated. And that is what I will show with most of the case presentations today, is that we are confronted with complications where things did not work so well for another practitioner or perhaps us, and how will we bring these things back together and provide the patient the optimal aesthetic outcome. And this is what we're shooting for. Everything meeting in the middle, where we've done the proper diagnostics, we've done the proper procedures, we've communicated properly with the patient in the referral, we've done our wax up to transition or transfer the expected outcome to the patient so they can see what we're doing ahead of time to deliver the final aesthetic outcome. Risk assessment is something that is key to our communicating properly, developing the appropriate expectations, and delivering the procedures that are going to work for us. And as I already mentioned, patient variables must be considered. All of this list here, their compliance and motivation, their financial status. That's sometimes going to lead us towards saving teeth versus replacing that with dental implants. Occlusion must be considered.